Good evening, everyone, and welcome to the Omega Psi Phi Fraternity Incorporated 2nd District Health and Wellness Monthly Webinar. I am Dr. Keith Boykin, your host. I am a retired pediatrician and internist, having practiced over 30 years. And tonight we will be having a conversation about preventative health and other health topics that relate to the African American and other communities of color. The views represented here tonight do not necessarily represent those of the Omega Psi Phi Fraternity Incorporated, but rather those of the individual brothers and or speakers. So with this being Minority Health Awareness Month, our purpose is to talk about prevention of different diseases and give details about different diseases as it relates to communities of color. So before we get started, I would like to introduce our brothers and have each brother on our panel give a brief synopsis about themselves. So we'll start out with Chairman of the 2nd District Health and Wellness Committee, Dr. Jedan Phillips.
Good evening, 78. Good to see you, my brother. Good to see you. Again, people, it is great to be here and to talk about such important information. Our theme in these monthly webinars have been the preventive health things that we can do as a community that can help improve our status. We are a community that suffers from preventable conditions such as heart disease, diabetes, screenable cancers, and we also, unfortunately, are not only a higher risk of those conditions, but we don't do the preventive things that are needed to predict them, to monitor them, such as going to see a doctor regularly, such as following up on abnormal test results. Or if somebody says, hey, your blood pressure is high, following up on that. These things are very important for us because, unfortunately, as we've seen in these previous years with this pandemic and this COVID-19 infection, it has chosen and affected people that are more at risk for health conditions as far as those individuals suffering more from COVID. So again, this preventive message that we are trying to get out here is critical, and it can not only help our regular health issues, but say if we have a pandemic, it can also protect us in those spaces as well. So I look forward to our conversation tonight, and thank you for all those who are in attendance.
Thank you, Dr. Phillips. Now we hear from Brother 95, Dr. Isabell. Please come on and give us your brief introduction.
Good evening. Glad to be here. Board certified internal medicine. I also do HIV primary care. Minorities are affected by a lot of common illnesses, diabetes, hypertension, heart disease, and even HIV in our population. That's even high. I'm glad to hear and share my experience and input on minority health. Thank you.
Thank you so much, Dr. Isabell. Now, Dr. 96, give us your introduction.
Hi, good evening. My name is Dr. Christopher Plummer. I'm a board certified OBGYN and maternal fetal health specialist. I specialize in maternal fetal medicine. It's interesting that last week was Black maternal mortality week, which we're trying to reduce in the United States. Maternal mortality and morbidity in Black women are at the highest. So this discussion is to emphasize primary care, keeping healthy, getting vaccinated, and seeing your doctor. So when you do become pregnant, you have a more successful pregnancy and outcome. Thank you.
Thank you so much, Dr. Plummer. And last but not least, 08, Dr. Ford, will you give us your introduction about yourself?
Yes, good evening. I'm Dr. Kelvin Ford, and I'm board certified internal medicine physician practicing in Prince George's County, Maryland. And as I mentioned, as internal medicine physician, I preach about prevention, screenings every day in my office, and hopefully we'll be able to impart some of that good knowledge to the people watching today. Thank you.
Thank you so much, Dr. Ford. So I'll talk a little bit briefly now about, preventative health and minority health awareness is not limited to the adult population. There are also certain diseases we encounter very frequently that can be prevented in the pediatric health space. So some of those things are, we now see a greater portion of our children developing type 2 diabetes, and we think it's related to pediatric obesity. Most children are indeed type 1, and that's a genetic factor, but type 2 is a preventable disease in children if we just have to manage their weight. So we talk about that among some other things. Athletes and pediatric athletes can also develop hypertension. So, again, it's not related to adults only in this field. Other things that we're seeing a rise in the pediatric population is use of substances. So we want to talk about substance abuse in the pediatric population as well. But before I get into any of those things, we're just going to start off with, the list of things I'd like for us to talk about tonight would be hypertension or high blood pressure, diabetes, cholesterol, alcohol, smoking, weight management, significant cancers, and last but certainly not least is mental health. Mental health is not a sign of being crazy. It's a normal part of our healthy prevention that we do. So let's start off with hypertension. I'm sure all of you guys have had some dealings with hypertension. So we'll start out with anybody want to tell what your current approach was, and then what is your population right now that you're seeing in communities of color with hypertension?
Well, what I'm seeing is that we don't check our blood pressure. We don't follow up. We don't follow up on blood pressure. And I had a patient come in of color who was at a work health event and was told, hey, you need to follow up on your blood pressure. And that was about a year ago. And only until they had to recently go to the emergency room because of a headache and vision changes as a result of their elevated blood pressure did they recognize how significant of a situation it was. So again, I think that one of the biggest statistics when you look at us and high blood pressures, we're one of the highest groups that have been told that you have elevated blood pressure and recommended or prescribed to take medication, and we're not taking the medication. So again, we have seen situations where you have individuals that have heart attacks, that have strokes, and other complications like kidney disease and eye changes or visual changes as a result of not taking their medication. And unfortunately, we have a lot of people that say, well, I don't want to take any medicines and I want to be able to monitor this and manage it on my own. But sometimes to complete that or achieve that, we've got to make sure that we're at least checking the numbers and make sure those holistic remedies, diet, exercise, supplements, that those things are in fact working.
So, what about, I heard you mention something about we don't take our medication, but what are the other factors, like such as lifestyle factors, may influence primarily and very heavily in the African-American community? Anybody can take that question.
Weight can influence it. I mean, unfortunately, we have a high level of obesity in our community. I think one of the other things, and this is something that's real as far as just our utilization of preventive care services, is we've got a historical hesitancy with trusting the medical profession. We don't trust medications. We don't trust the providers. And I'm not saying that that's the right way to go about it, but you've got to look at the reality of how people feel. In addition to that, when we look at advocating healthy lifestyle practices, how many of our patients or people that look like us live in communities where they have food insecurity or lack of quality access to resources that could assist them in exercise or other wellness activities?
There's also how we
balance. Yes, go ahead, Dr. Ford. I'm sorry.
Yeah, so how we're eating, we tend to eat a lot of foods high in salt, right? So, whether, like you said, canned foods, or we just are in love with the salt shaker, putting salt on everything, that tends to elevate our blood pressure. So we have to make lifestyle changes as far as not adding salt on your food, cutting back on like the chips and the pretzels and the peanuts, all those things that are salty. And the other thing is what Dr. Phillips said, we have to exercise, but not only, we don't necessarily always have to go out to exercise. All we need is a room that's 12 by 12, right? And you can do jumping jacks. You can get a little stepper to go do steps. You can do sit-ups. You can do all of those things. And so, you know, we can't make excuses, right? Basically, we have to want to try to exercise, and we have to try to eat a little bit better.
I agree with you wholeheartedly. I'm gonna come to you, Dr. Isabell. You know, one of the things I always tell my kids, especially the adolescents that have hypertension problems, the simple exercises they can do is, you talk about, all you need is a room at home. If you like to watch TV, well, stand up in front of the TV and step in place while you're watching TV. You'd be surprised how many calories you can burn there and how much conditioning you can do for simple as that. So I just want to put that little piece in there. Go ahead, Dr. Isabell. I saw you wanted to add to that particular part.
It's particular part of prevention or other things that can cause hypertension. As we know, alcohol can cause hypertension, as well as smoking. And then you may be on certain medications, for example, for mental health. They can raise your blood pressure. What is hypertension? We say the systolic, which is average, is greater than 140 or greater, or the diastolic is the lower number is 90. So hypertension is systolic is when your heart is actually pumping and working, while diastolic is when your heart is relaxing. So that's the bottom number. But the preventive measures is, as we said, exercising, avoid stress, lack of sleep apnea with obesity, that also can affect your blood pressure. So these are just some of the other things that you may need to be checked for or be aware of.
Okay, when we heard from the internist and about, particularly we talk about all race, but let's talk about how it affects women in pregnancy, Dr. Plummer. Give us your take on that, please.
Well, I mean, heart disease is still like one of the #1 killers in women. High blood pressure is one of the things. It's also a silent killer. So if you don't really get serial or follow up with your doctor and get your blood pressure checked, you will never know. Also, when people finally get pregnant and they finally see a doctor, or when a woman gets pregnant and she finally sees a doctor, we finally realize that she has high blood pressure. And high blood pressure during the pregnancy, if it's not well controlled, it can cause issues with the growth of the baby, and also it can increase the risk of preeclampsia, which is elevated blood pressure and spilling of protein in the urine. And we don't know what causes it, but we already see it in pregnancy, and the only treatment for that is actually delivery. And if her preeclampsia is very early and very complicated, it might lead to a very early preterm delivery of the baby, which can also have long-term consequences for the baby, and also long-term consequences for the patient, because when you do happen to have preeclampsia, it does increase your risk of developing heart disease later on in life.
Thank you. You touched on a couple of points that I want to make sure you bring out. The infants born to mothers that have hypertension, usually smaller infants, and a management problem with eating and so forth and so on like that. But let's talk about, family history. What role does that play? How is family history important in talking about hypertension? Anyone want to take that question for me?
Well, I think, again, when you look at family history, it can put some risk on you. So if you have a family member that died from heart disease, and they're, say, under the age of 55 or under the age of 50, that can put a significant risk on you. But I think the other thing, when you look at family history, is also the circumstances that may surround that group. How people eat, how people may have a propensity for exercise or not, how people's physical disposition. Like for me, I come from a full-figured family. So there's a pressure for me to make sure if I don't want to become obese, that I have to stay active, that I have to eat the right things, you know. But again, I think having that awareness is important. But, you know, the other historical thing is how many of us can say that our families have these medical issues and we don't talk about it amongst each other. So I think that family history is very, very important, because that can let you know, again, this is something I really, really need to pay attention to. And it's not something I need to be so casual about.
Yeah, because you mentioned weight. Weight is probably a big issue in adolescence in terms of hypertension. You know, most kids that have hypertension, when I first see it, I see they're overweight, and so sometimes simply reducing their weight can help with hypertension. Although some kids go on to have be on medications, and it's not related just to athletes either. Family history wise, as you talked about, you know your family history. I think the youngest patient that I ever diagnosed with hypertension was a 3-year-old child, and actually was picked up by my medical assistant, you know, because we base things on percentiles in pediatrics, and this child was very much outside of the 95th percentile for her systolic and diastolic pressure. So family history is very, very important. Dr. Isabell, I saw that you flashed me. You had something you wanted to say further about that, about hypertension. Sorry.
About hypertension.
Okay.
Well,
Yes.
I'll just add, sometimes we mention kidney or if you have like polycystic kidney disease, sometimes, you know, that can affect your blood pressure, or some type of gene defect of less common things, less than 1% of these genetics can also put you prone to high blood pressure. Thank you.
Okay, brother, let's pause a minute, because 92, brother Dr. Wingfield just joined us. So I'm going to ask him to come on and give his a brief introduction of himself, because we've been talking about things that related to his specialty. So Dr. Wingfield, come on and give us your introduction. Can't hear you.
Mike. Can't hear you.
Can't hear you. You muted again. There you go. Okay, I think we lost him on the sound thing. So we'll come back to you, Dr. Wingfield. We won't forget you tonight. So are you there? Okay, we won't forget you. So, you know, we've been talking about hypertension, but I heard a lot of things mentioned during the discussion of hypertension, and then there are other things that relate to hypertension that we've already talked about. And one of the biggies in the African American community, African American community and communities of color, is diabetes. Diabetes is a big issue in African American people. So let's talk about that, Dr. Ford. Tell me your experience with diabetes in your practice.
Well, we know diabetes is so common. Almost 2/3 of the population either have diabetes or are pre-diabetic. And so diabetes basically, you know, I see probably at least 8 to 10 people a day that have diabetes, right? And I'm sure that's pretty much common with the other Dr. Phillips and Dr. Isabell, who see patients, you know, in the office. And so we have to really, diabetes is about also how we're eating, right? Exercising.
Mm-hmm.
That can help to try to control the person's blood sugar. And so when we talk about eating, we're talking about avoiding foods that are high in sugars. Even certain, I give a diet sheet to my patients, right? Even certain fruits, they're amazed that, man, I can't eat that orange or the pineapples or the watermelon, all those good sugary fruits. But we need to shift that to more, you know, berries and apples and cantaloupe and all of those things. So it's about how you're eating. And I can probably go on all the potatoes and white rice and pastas. You know, we have to change how we're eating, and that can help to control our sugars, but also the exercising, right? So I think diet is a major, I think we keep coming back to diet on blood pressure, diet on diabetes and all these things, you know, and exercise. So Those are some of the things I think we should impart on our patients.
Dr. Isabell, you
diabetes.
Want to add to that?
Yes, I want to, regarding diabetes, just like Dr. Ford says, almost every day in the office, I see a patient that is either a diabetic or a pre-diabetic. Pre-diabetes is also very important because it puts you at higher risk of developing diabetes. What's pre-diabetes? We use the hemoglobin A1C, which monitors your average glucose level over the last couple of months. Pre-diabetes range is 5.7 to 6.4, while diabetes is 6.5 and higher. So we try to prevent somebody from becoming a full-blown diabetic by trying to help with diet earlier, lifestyle changes earlier. For example, also if they drink or exercise. So that's what we do with pre-diabetes. I've seen that a lot also.
So Dr. Phillips, he mentioned the term pre-diabetes. I mean, how important is for people with quote unquote pre-diabetes to check their blood sugars, or should they check them, or what should they do about their blood sugars other than watching what they eat? What advice would you give people that are pre-diabetic that are listening tonight in terms of checking their sugars?
Well, I think Dr. Isabell just said it. If you're a pre-diabetic, you're at a higher risk of becoming a diabetic. And again, unfortunately, a lot of times the lifestyle, this is your opportunity to start to institute those lifestyle changes to protect yourself from that progression. And with that, you've got to monitor it. Just like I mentioned earlier about blood pressure. Somebody says you're pre-diabetic. That doesn't mean I'm going to exercise and work out and I'm not going to follow up on my sugars. Now, again, when we say follow up on your sugars, does that mean that you need to check your sugars every single day? No. Does that mean you need to do finger sticks at all? Not necessarily, but it does mean that you need to follow up with your doctor. As Dr. Isabell mentioned, the hemoglobin A1C, which is that average sugar level that gives us the staging. Another thing that I wanted to add on with diabetic status is the importance not only of getting glycemic control, which is control of your sugar, but the importance of preventive practices, checking your feet regularly, going for your eye visits annually, getting your urine microalbumin checked to check on your renal function or kidney function, because that can be impacted. And I'm telling you, folks, it's the springtime. We getting ready to go into vacation season. Let me tell you where I see our diabetics manifesting on those vacation trips. I just had somebody last year in the Bahamas. Their diabetes wasn't in control before they left. What you think is going to happen when they're on that Tom Joyner cruise ship? They're going to be eating. And unfortunately, that is not the infirmary that you want to have a problem in. And this particular patient, their diabetes manifested when they landed in the Bahamas and they had to go to the hospital. And that created a whole nother level of complication. In addition to that, checking your feet. Everybody wants to get these nice sneakers. We all had that pair of shoes that might be a little bit like they just don't fit quite right. And you going on a trip. I just had a patient, went shopping to Italy, the trip of a lifetime with her daughter. And she went to the nail salon to get a manicure, pedicure, and they cut her toenail too short. She goes on this trip. Again, her sugars weren't great already. Goes on this trip, walking an incredible amount every day. Now she's coming back and we having complications. Can we save her toe? So again, monitoring so we can prevent progression. And if we are seeing progression, and then what I mean by progression is if the diabetes or pre-diabetes is worsening, then we've got to come up with other strategies to monitor it. But the other part is making sure you take advantage of the preventive recommendations that go with being a diabetic. And I'm going to end here. if you've been a diabetic once, you are always a diabetic. You just could be a diabetic that's under good control, but that doesn't excuse you from checking your feet, getting your eyes checked, checking your urine to make sure your kidneys are safe, and going to the doctor regularly and having a test like your hemoglobin A1C. Now, the benefit when it's under good control is you just don't have to do it as frequently. Once a year, once every 6 months. But if your A1C is out of control, what is out of control? Over 8, over 9, you know, you're going to be seeing the doctor every 3 months, and you could complain about it and you could get upset and get angry like this is really inconveniencing, but be inconvenienced in Italy and then tell me what you feel about coming to the doctor's office.
Wow.
Also,
thank you, ADA. I'm gonna get Dr. Wingfield in just a second, Dr. Plummer. I want to make one small point here. Just because you are not overweight or you may be skinny or lean, an abnormal fasting blood sugar is an abnormal fasting blood sugar, and you are still at risk for you're still pre-diabetic, and you're still at risk for developing diabetes. Before I get to you, Dr. Plummer, let's have Dr. Wingfield introduce himself, then I'll come back and get your question, Dr. Plummer. Go ahead, Dr. Wingfield.
Hey, good evening, everyone. Hopefully you can hear me.
There?
Dr. Wingfield, one of the interventional cardiologists, the bros. But you know, this is something that we talk about on a regular basis. Diabetes is something we all deal with every day. And when we talk about heart disease, especially from a cardiology standpoint, diabetes is a coronary equivalent. It is equivalent. If you're diagnosed with diabetes, it is equivalent to someone who has had a heart attack. So when we treat a person who has diabetes, we treat them as aggressively as someone who has already had a heart attack, right? Because we always talk about that your cardiac risk, okay, or ASCVD risk calculator, okay, your risk of a heart attack or a stroke over the next 10 years. And if you calculate your risk of heart attack or stroke and you plug in diabetes, it is going to be the equivalent calculation of someone who has had a heart attack. So what does that mean? If you are diabetic, then we aggressively control your not only your blood sugars, but we aggressively control your cholesterol. Right. So the goal cholesterol for you is going to be a LDL, a bad cholesterol, less than 70, and it may be less than 55. So a lot of times you'll see your primary care doc and they'll say, yeah, we want to get you down under 100, but you go down the street to your cardiologist and then we say we want you under 70. OK, so automatically, if you are diabetic, you're going to be started on a statin. So we typically start you on a statin the same as I would if I had someone walk into the office who had a recent heart attack, because we know that what diabetes does, it affects the blood vessels. Okay, so the blood sugars over time does cause a hyperinflammatory state. And this chronic inflammation is damaging to the blood vessels, allowing plaque or cholesterol to penetrate the arteries and start to stack up in the arteries. And that increases your risk of heart disease. Also, from a neurologic standpoint, those elevated blood sugars, yeah, it affects the nerve endings. Okay, so when blood sugars are elevated over time, it affects the nerve endings. And you may not feel when the physician, or not even the physician, when the nail salon is cutting your nails, right? And cutting them too low. You don't feel that because you have the neuropathy from long-standing diabetes. Well, what does that lead to? Well, you already have problems with your circulation. Blood flow is not getting there. You don't feel the damage to the toe or to the foot, and you end up with some sort of infection. And with lack of circulation, the antibiotics don't get to that area, and you're at much higher risk of limb loss or what we call peripheral artery disease. So in the diabetic patients, it's just the tip of the iceberg. And diabetes, it is a reversible condition. If you're diagnosed with diabetes, yes, you always have diabetes, but with diet, exercise, monitoring your blood sugar, weight loss, you can actually reverse your diabetes and avoid the issues with your circulation, with your nerves, nerve endings, with heart attack and stroke. So we really got to just treat diabetes aggressively because, as we say, it is the tip of the iceberg, and it does lead to many, many problems if it's untreated. And if it's treated, there's so many effective therapies at this time. So I'll end with that.
Thank you. Go ahead, Dr. Plummer. You had something you want to say. I know it's a little bit different from you in your field with pregnancy and diabetes and all other kinds of things and with maternal health. Go ahead and tell us what you wanted us to know about your perspective.
Just like everyone else, uncontrolled diabetes can also cause complications in the pregnancy. With uncontrolled diabetes, usually we like a hemoglobin A1C, if we're talking numbers, of 6 or less before you attempt pregnancy, because the higher the hemoglobin A1C in the uncontrolled diabetes, during conception, as the embryo, as the fetus is developing, it can cause a lot of abnormalities, especially in the heart. So we like to have a very more tight controlled diabetes than even if your internal medicine doctor would like to have tight control of your diabetes, especially when you're pregnant, just to reduce the chances of the baby growing too small, or most of the time the baby growing too big with uncontrolled diabetes. So, and then that can lead complications with birth. It leads to babies' increased risk of cesarean section, and also complications for preeclampsia. So diabetes is also a very important thing in the pregnant patient. And a lot of women don't know that they have diabetes until they become pregnant. And then all the screening and all the testing that was never done before is done during pregnancy. And now you have to deal with the medical complications, and on top of that, the pregnancy.
Yeah, you talk about I'll come to you, Dr. Isabell. Okay. I just want to make a quick point about the babies, because babies of diabetics are very large babies, and they present a problem in the neonatal period with maintaining and managing their blood sugar. So that's why it's important to know and manage, what your OBGYN or your primary care internist or family practitioner tells you about managing your blood pressure, and you're pregnant. You better do it, because you're not only risking yourself, but you're risking that baby for complications after birth, and may end up in the neonatal ICU, for something that, you could have controlled by managing your blood sugars. I'm sorry, go ahead, Dr. Isabell. I just want to make that quick point.
Yeah, to add what brother Dr. Plummer was saying regarding control of diabetes and pregnancy, a lot of times, even if a patient was type 2 and they were on oral hypoglycemic, anti-hypoglycemic medications, we would put them, they either see endocrinologist, or even we put them on insulin, because it's better, tighter control. And eventually, after the pregnancy, sometimes we convert them back to their previous medications. That's all.
So, there's so many different types of medications out there for diabetes. Now, anybody want to tackle that? Because it's direct to consumer advertising about diabetes. It makes me confused. I'm a physician, about all the things out there they're advertising people. Anybody have any thoughts on that?
Well, I think I'm sorry. You go ahead, Dr. Plummer.
No, I was saying the best, invention was insulin, and I have to thank Dr. Benning for inventing that, because that saved a lot of people from going into DKA, dying of acidosis, and also maternal deaths. But insulin, at least in my area, is probably the best one to control, just like Dr. Isabell was talking about. Metformin is a close second, but that is more for gestational diabetes and not for pre-existing diabetes for management in pregnancy. But then you guys talk about all the other ones that are really not compatible in pregnancy at this time.
Dr. Ford, you wanted to add to that?
Well, we have multiple new medications that are out that can help out to control diabetes. Some which also, I'm sure Dr. Wingfield would probably talk about, will help out, give you some cardiovascular, will help with cardiovascular disease, and also renal disease, kidney disease. We know about Farxiga, Jardiance, those medications. But then also we know about all the weight loss medicines, the GLP-1 inhibitors, which is a major game changer as far as helping to control weight, and helps to improve the patient's blood sugar. I think it's also been shown too in heart disease also, I believe, Dr. Wingfield, some of the SGLT1 inhibitors. and the Farxiga, the Farxiga and the Jardiance, but also the Ozempic, Wegovy, Mounjaro, and all of those particular medications. So we have a lot of medications now that we can use, but also tailor to whatever the patient's needs are. Also,
I think
that's a very
also
good
to
point.
add on and talking. Go ahead. I'm sorry.
Go ahead.
I think we're talking
No,
about.
just go ahead. Go ahead, Dr. Phillips.
When talking about the medications, I think it's also important to recognize, as it was alluded to earlier, is that the more aggressive we are in correcting this, the better we're able to take away that toxic environment within your body of that elevated sugar. So, I get a lot of people, they put a lot of pushback on medications. And when their diabetes is unfortunately bad enough, they even push back on insulin. And they're not really understanding, like me walking around with a sugar of 250 all the time is toxic for my body. Just another thing to add, the new hotness right now is the GLP-1 inhibitors. You get patients that are pressing you about, hey, I want you to put me on this medication, and they don't even have diabetes. And the unfortunate part of it is created a scarcity in the availability of these meds for individuals that truly would benefit from the effects of it, including the weight loss and the glycemic control effect of it.
So, I haven't said much about type 1 diabetes tonight. So that's a whole different feeling, we can have a whole different webinar on type 1 diabetes. But just suffice it to say that there are things out there for kids. If you're afraid your child has diabetes, have to have their fingers stuck so much, there are these things called CGMs, continuous glucose monitors, that can monitor that. And they don't have to worry about having their fingers stuck all the time. So I want to say that, if you have diabetes, don't be afraid to go see your primary care physician, because they can help you manage it and get yourself safe. Into a different space and a healthier space. Go ahead, Dr. Wingfield. Are you there, Dr. Wingfield?
I think just to add on what you were saying is, and this is for our bros in the environment listening to us, because it's a conclave year, and I can remember going to the conclave in Philadelphia, and my road trip companion, a brother, we're eating, hanging out, being festive, and he starts feeling different. And at that moment, now there's a disclosure that he has diabetes and it's not under good control. And now, instead of in a weekend of enjoyment and being able to take care of fraternity business, my weekend was spent playing doctor. And I didn't go there to be a doctor. Now, on the funny side of it, when we road tripped after that together, I said, team, I need a medical clearance before you can get in the car. But again, the point I'm making is, if we don't take care of this on the front end, we got to deal with it in spaces that it can get in the way. For example, if you want to have elective surgery, I just had hip replacement a couple years ago. If I had diabetes and it was out of control, that could have prevented me from having my surgery done. If you get an infection or any type of illness, many times it can be complicated with diabetes, causing, if you were admitted to the hospital, prolonging your stay, again, just increasing the level of morbidity and, that you can have as you deal with a medical condition when diabetes is not under good control.
Okay, Dr. Wingfield, I think we got you back now. Are you back with us? Looks like he's frozen again. All right, guys. So I just want to give a personal touch on diabetes, because I think it's important. For years, I had an elevated fasting blood sugar, and back in those days, primary care kept telling me, "Oh, don't worry about it." Well, this is just, I'm making a point of family history. So when I went to see another primary care physician and told him about cholesterol running in my family, told about my people in my family, I always said they had a touch of sugar. He went ahead and checked my hemoglobin A1C, and guess what, folks? I said, "Go ahead, have fun. It's gonna be normal." My hemoglobin A1C was 7.0. And I'm a very slim, small person. I'm not overweight. And I was also watching what I thought I was watching pretty good, what I ate and everything like that. So the point is, family history is important, because those elevated fasting blood sugars should have been addressed before and dealt with. and I ended up having to take oral agents on it. I'm still on those oral agents now, but I'm doing very well with it. So the point is, family history of diabetes is very, very important, because again, you don't have to be overweight to have diabetes, but overweight is a big, big factor in a lot of us in terms of having diabetes. All right, Dr.
Boykin, let me just chime in because I'm having a choppy feed, but just in terms of those new medications that we have out there for diabetes, obviously the GLP-1s, which is your Ozempic, your Manjaro, those medications that are hot right now. Wegovy and Ozempic are the bigger ones. But the thing about those medications, yes, they are indicated for diabetic patients. Typically what we will see, these are injectables that you inject once a week. We do see at least a reduction in your hemoglobin A1C of about 1 point, okay? A reduction on your hemoglobin A1C. And a lot of physicians are using these as first line. Typically, your welcome to diabetes medication was metformin, which a lot of people would have GI side effects and upset stomach and things like that. But these medicines, Rybelsus and Ozempic, are being used far more frequently for diabetic patients, especially when they're superimposed obesity. So we do get good benefit. Those medications do curb the appetite. They slow the flow of contents through the digestive system, so you don't eat as much. And then also they optimize your glucose and your insulin levels. So they are healthy from that standpoint. And obviously the side effect is weight loss. Okay, so that's why it's so hot, where they're coming up with new indications and just change the name. So Ozempic is actually also called Wegovy. Okay, so if you're just obese with one risk factor, obese with hypertension, we can prescribe Wegovy for weight loss and get effective reductions in your blood pressure. Overall cardiovascular health also improves. So these medications have become beneficial to treat obesity as well. So they're actually, if you look at it, they're putting a dent in the bariatric surgeons' work, because patients are getting on these medications, because the thought before was, look, if you lose 100 pounds, I can get you off the diabetes medications, I can get you off the blood pressure medicines. But we're seeing that there is benefit with these medicines, and also the SGLT2 inhibitors, the Farxiga and Jardiance. Those are medications that have a heart failure indication. So if you have reduced ejection fraction 40% or below, those medications are indicated to benefit the cardiac remodeling, volume and fluid status. So there are some medications out there that have proven benefit, and they've been studied. Please, I recommend you see an endocrinologist, see your primary care doc, see your heart failure specialist. But there are multiple ways to treat diabetes, obesity that we didn't have a couple years ago.
I think one thing to add when you're talking about these GLP-1 medications is their contraindications. Again, and also the awareness you need to have, like if you're having a procedure done that you need to hold it a certain amount of time before the procedure. A lot of times people are just so focused on the weight loss aspect, they could put themselves at risk if they're not allowing their medical provider to provide them with the instruction on how to use it, especially if I'm going to have my colonoscopy done. If I'm a person that has had pancreatitis in the past, this may not be the right medication for me. So the contraindications and how to take medicines around a procedure is very important as well.
Dr. Isabell, you indicated you had something else you wanted to add?
Well, Dr. Phillips said it. I'll just add also, if there's a family issue of thyroid cancer disease, that's another contraindication. If you have inflammatory bowel disease, Crohn's, ulcerative colitis, you better be cautious, because you can have complications of obstruction. So also these medicines, Ozempic, Wegovy, being in primary care, they are good medications, but I have to also inform you of some of the bad side effects. It does, if you don't, you lose it. I've seen with patients who have been on 1-2 years, and they may reach a peak of losing weight on these medications. Also, it can cause muscle wasting. So that's why anybody who's on these, they may still generalize weakness. So being on this medication, it's not for weight loss. It's not the wonder pill. You still have to exercise and work on your muscles so you don't get that weakness. And then I just see where patients they forget about exercising, and they're not working on their cardiac, their heart, and they're just focusing on that. So that's what I'm seeing in primary care, and I try to focus. You still have to exercise. You don't cut that out. That's what I've noticed with these new medications.
The last point I want to make before we move to the next topic is these medications we're discussing, the Ozempics and things like that, they're not for type 1 diabetics. Type 1 diabetics in childhood is insulin dependent. These medications are not indicated for the use in children. So I don't know about type 2 pediatric indications at this particular point, but you would need to discuss that with your endocrinologist, your pediatric endocrinologist. Type 1 diabetic patients can have insulin pumps going, and so different things to deliver insulin these days. So it's not like it was in the old days, getting shot so many times. I think the youngest child, again, that I ever diagnosed with type 1 diabetes was a 12-month-old baby. So it has no age group. Diabetes knows no known factors. Now let's get into some of the things that people don't like to talk about a lot, I think, in the communities of color. And we touched on it somewhat. We talked about smoking and use of alcohol. What are the things that harm us as African Americans from smoking? I think Dr. Wingfield talked about it from the heart standpoint. And we didn't talk about lung disease with cigarette smoking, such as COPD, and alcohol. Let's talk a little bit about smoking. Your patient it's not an easy thing to stop. I realize that it's an addiction, just like anything else of substance. But let's talk about smoking. Who wants to take a first stab at smoking? Go ahead, Dr. Plummer.
Well, I mean, smoking is addictive, and we do see it in the pregnant population. For some reason, there's a lot in the African American community. Menthol cigarettes are king. Cools, Newports. For some reason, I don't know if they have an addictive quality because of the taste, but smoking can cause stillbirth in pregnancy. It can cause growth issues in pregnancy. It can also cause preterm delivery. And also alcohol is another issue that we also see in the African American community, especially with malt liquor, with the fascination with Hennessy, and alcoholism is another issue. And in pregnancy, it can cause malformations, and it can cause a lot of issues during the pregnancy. So that's also something that we have to try to combat.
So, brother doctor, is there any difference between me smoking a cigarette and a cigar? Brothers love to smoke their cigars. What's up with cigars and cigarettes? Difference in brothers smoking them? Anybody want to take a shot at that? I guess not. But the point is, go ahead, Dr. Isabell.
Well, regardless,
some of them have been in the cigar lounge themselves.
well, it depends on how frequently you smoke cigars. If you do it occasionally, it may be all right. But if you do it every single day, like you smoke a cigarette, the risk is the same. So it depends on how often you smoke a cigar.
But the problem is also the addiction of the tobacco. That's
yes.
That is also the concern.
And the tobacco, or even smoking a tobacco pipe. And to add regarding smoking and alcohol, it increases risk of strokes. It increases risk of heart disease and cancer. We know about lung cancer, but it can also increase risk of alcohol, esophageal cancer, along with smoking in African Americans. A particular esophageal cancer, squamous cell, which is common because of smoking. And we can't forget about abdominal aortic aneurysms due to smoking. So these are some of the risk factors that have affected our community.
And pancreatic cancer, which is one of the most difficult ones to screen for, and by the time it's diagnosed, is really advanced.
Right.
Right.
Folks, just for quickly, this is Esophageal Cancer Awareness Month as well as Minority Health Awareness Month. So go ahead, Dr. Ford. Did you have something you wanted to add, Dr. Ford?
Yeah. I mean, when we're talking about smoking, even bladder cancer is associated with smoking. But one of the things as far as screening, as far as smoking concerns, screening for lung cancer. And we know that nowadays we're talking about patients that have smoked more than 20 pack years of cigarettes. And by the age of 50, they should start getting screened with a CAT scan every year, I believe, up until the age of, I think it's 80. And it was 75. I think they moved it to 80. And so with lung cancer, it's the #1 cause of cancer death, right? Because if you get lung cancer, if you don't catch it early, it's a bad prognosis. So getting that CAT scan every year, once you've smoked for 20 pack years, beginning at the age of 50. But the ideal thing is don't smoke, stop smoking.
Oh,
right?
and just before we just go with that, we know about smoking and lung cancer, but there's also environmental things such as radon, which might be in certain people's homes, and to at least test for and to mitigate, because that radon exposure is the second leading cause of lung cancer after smoking. So that is another lifestyle, change to help reduce risk of cancer.
Are we affected by secondary smoke? If anyone tells about secondary smoking, go ahead, Dr. Wingfield.
Yeah, I mean, absolutely. The secondhand smoke in many studies is equivalent, right, to actually smoking. We all get annoyed. We see these little kids in the backseat of a car and someone smoking, and they got the window barely cracked, if that. And the kids are being exposed to secondhand smoke, causing damage to the lungs, damage to the airways, to the alveoli of the lungs. And we see this, obviously, with smoking. We also see this with vaping, right? These younger kids are vaping at a very early age. At high school graduation parties, they got the vape, the vape station, and these kids still developing from a cognitive standpoint. Bodies are still developing, and they're introducing these carcinogens into the body, causing damage to the lungs, to the circulation, to the brain. So there's no free lunch. And the addictive nature, even of the vaping, the tobacco abuse, it is one of the most addictive, if not the most addictive drug out there, is that nicotine from smoking. So there's no free lunch, damage to the arteries, damage to the circulation, increased risk of heart attacks, increased risk of strokes. And if you know all this going in, you really have to quit or don't even think about smoking, right? Or vaping or any of the other things.
But the
one thing that I'm just going to add real quick, the cigar smoking, erectile dysfunction, right? That is one of the big ones. Look it up, research it, look into it. But all these guys talking about, coming in, looking for Viagra and Cialis and the others, you got to quit the smoke. You got to quit the cigars, right? You got to quit the cigars.
Well, and also the way they target the minority community with this vaping, and how many these new vaping shops you start seeing around there with these certain type of flavor, vapes that are out there that target the community and get especially the younger ones addicted to it. And we also see that in our pregnant patients too, which nobody knows what is in the vape material. So we also recommend that they stop vaping while they're pregnant.
Yeah, the American Academy of Pediatrics has been a big on a big bandwagon about vaping in adolescence, because people had thought at one point that vaping was a way to get off cigarettes, but it's the opposite. The opposite is true. It's just more addictive than smoking cigarettes when you vape. So, all right, we don't have much time left, but I do want to talk about a few things like we need to talk about mental health. I want to just say that mental health is, I want people out there to remember, forget the word crazy. There's no such thing as crazy. Crazy has nothing to do with mental health. Mental health is just another part of our regular preventative health checkup. So, if you have issues that are related to mental health, please discuss it with your primary care and seek appropriate referral if you need to. I want to say that quickly. If anybody want to add anything else to that, go ahead right now, because we want to talk about the 5 biggest cancer killers in African Americans too. So, any other thoughts on mental health?
Just briefly on mental health, when you see your doctor, you go for preventive, they may ask you questions for screening for depression as well as anxiety. And then and I ask you to answer those questions honestly, because you're only just not helping yourself or your friends or family. And I know sometimes patients may not answer those questions true. They may say no when they see the nurse, or maybe they want privacy, but then they say yes when I bring it up. But that's if you have a good rapport with your doctor. Mental health is an illness, it's undertreated, but it's very important.
Thank you. Thank you so much for that. Dr. Plummer, did you have something you wanted to add to that?
Well, I mean, also, if postpartum depression is also a strong issue too, because after changes in hormones, taking care of a new life, sleepless nights, they might be alone and might not have enough support. So it's one of the things that, not to be afraid to ask for help, and also don't be afraid to check on someone and to say how you're doing. Are you okay? Because somebody might open up to you about that they're dealing with something and might then seek help. So those are the things that are important, because suicide and depression are also things that affect the minority community. And we just have to try to reach out to a lot of people, because there's a lot of stress and a lot of people struggling out there, and we just don't know.
We actually have a postpartum depression checklist screening in pediatrics now, because postpartum depression is so prevalent, particularly in first-time mothers. So we as pediatricians is coming upon us to screen for postpartum depression in these day and time. So we've got about 2 minutes left, guys. So I want to just briefly touch on the major cancers that have affect our community. Anybody just want to give a brief statement about the ones that African American people need to be concerned about, or other communities of color need cancers that we need and that are killers of us? Go ahead.
We need to be concerned about the screenable cancers. We need to be concerned about colon cancer. We need to be concerned about prostate cancer. We need to be concerned about breast cancer. We need to be concerned about cervical cancer. As Dr. Ford just mentioned, there are screening tests now available for those at an increased risk of lung cancer. I think we could bring up these cancers, but the act of prevention and screening is more what we're trying to get at, because, again, that is important. So that's my quick. I don't want to take away from my brothers.
Go ahead. Anybody have anything else that they wanted to add?
Oh, Dr. Phillips hit it all.
Okay.
All bam.
Well, folks, we've had a lively discussion tonight. We talked about so many things with us. We could go on for another hour or so about the things we need to discuss and talking to African Americans and communities of color. But at this time, we do have to recognize that our time is just about up. So I'm going to give each brother a few seconds to give their final takeaway. We'll go ahead and start with Dr. Ford, your final takeaway. Unmute, brother.
We definitely touched on a lot of different topics. I think what we just hit at was prevention, screening. You should make sure that you follow up with your primary care physician so that they can make sure that they're touching on all the different aspects, from diabetes, high blood pressure, screening you for all the cancers. Thank you.
All right. Dr. Plummer, go.
Good evening again. It was always a great discussion with the brother doctors about everything. We just keep on all the same theme. screening and prevention, and that can reduce a lot of complications that we see in our community.
Dr. Isabell.
Prevention. We have just briefly. We have conferences coming up that grant all the conference and regarding HIV. We're 12 African Americans are 12% of the population, but we're still 40% of the new cases, as well as STDs. Is higher in the African community. So these conferences that are coming up, that we're going to protect yourself. That's all I have to say.
Thank you. Dr. Wingfield.
Yeah, just quickly, a great discussion once again. I'm with brother Phillips with the action, right? We need to come up with an action plan. We love having our family members and relatives and friends and all watch these webinars, but we also want to see action. So go out, get a blood pressure cuff, go to CVS, get a quality blood pressure cuff, keep it around the house, monitor your blood pressure, right? Call your physician, schedule an appointment, get in, get screened, figure out what your PSA level is. Find out when's the last time you had your colonoscopy, get your colonoscopy done, check your blood pressure, check your blood sugars. Action is everything. Thanks.
Thank you. Dr. Phillips.
Thank you, everyone, for, to my esteemed brothers, thank you for giving your time to participate in this conversation. We wouldn't be here if it wasn't for the support of our district representative, Mr. Delrico Gales, and we appreciate his support throughout. I'm going to just say this: prevention costs you a whole lot less than reaction.
Thank you, Dr. Phillips. Well, there you have it, folks. We talked about prevention, intervention, action, and family history. So what we want you to take away from this tonight is make sure that you're doing some preventative stuff. You're in concert with your primary care physician and doing your part to maintain yourself. Again, as Dr. Phillips said, we'd like to thank our district representative, Brother Delrico Gales. We also like to thank Brother Piercy behind the scenes, who makes it all possible for us to do these things. I'd like to thank the brothers of the on the panel and the brothers of the fraternity. And last but not least, I'd like to thank your audience for coming to hear us every month and giving us the inspiration to do these things. Thank you very much, and everybody have a great day, a great night. Thank you.